Good evening. Welcome to the annual supporters meeting at the Glaucoma Research Society of Canada. I'm Jim Parks, the president of the society, and I'm going to be dealing with some introductory comments before handing over to others. You're all aware from earlier communications that we had hoped to have an in-person meeting, as we always have in the past. COVID-19 has put the kibosh on that. I hope you're all coping as best as you can to deal with the pandemic, and we all hope to get back to some semblance of normalcy at some point. But for the time being, we're dealing with this webinar. It's the first for us, so I hope you bear with us if we encounter any glitches or things that we haven't thought about. And thanks to all of you for taking the time to participate. We really appreciate it. And we're hoping we'll have a real meeting next year. And in the meantime, hoping that this presentation is both informative and useful for what follows. First of all, we want to thank Santen Canada Inc., which has generously sponsored this meeting financially. Santen Canada is part of the Santen International Group, whose fundamental approach is to contribute to society in general by targeting its efforts on ophthalmology with special focus on patients. Santen Canada's commitment to the community is to improve the quality of vision health and offer Canadians a brighter future by providing innovative medicine. Just a few words about the society. Some of you probably already know this. It's a corporation formed under federal law, registered as a charity with Canada Revenue Agency. That enables the society to issue official receipts for donations and also requires it to comply with the income tax law, keep proper books and records, and file an annual tax return, which we do diligently. Financial statements are audited by outside auditors. We'll talk about that a bit later. The affairs of the society are overseen by a board of 11 directors who spend a lot of time, all volunteers, of course, with diverse backgrounds, which contribute to the inner workings of the board on a regular basis. We're also fortunate to have Suzanne Marshall as our administrator. Suzanne came on board in January and has been very helpful, particularly through the pandemic. The directors are elected for 3-year terms, and I'll just come back to them in a second. If we were holding this meeting in person, I'd ask the directors who were in the room to stand up and wave and identify themselves. We can't do that, so in lieu thereof, I'm going to introduce them and we'll show their photos and a brief description of who they are and what they do within the society. Starting with me, just because I happen to be the president. A little bit of information about me, nothing particularly. I'm a lawyer, not that it makes any difference. Next, we have Martin Chasen, who's the past president and an accountant. After Martin, we have Dr. Trope, who everybody knows. He's really the founder behind this. Not only a director, but chair of our scientific advisory committee. And then Dr. Burt, who's the vice chair of that committee. Dr. Bendlish, we'll hear more from him on the question and answer period. Dr. Blair Fearon, Dr. Mark Schaefer, our executive secretary, Renee Wolf, our vice president, Mel Mitzel, and Tom Gottlieb, our treasurer, who will have more to say shortly. The underlying purpose of the society, as I think you're all aware, is promoting and providing funds for medical and scientific research, grants, and that's really what we're all about, is raising money to make grants to researchers to achieve our purposes, which are set out really to be research into causes of, control of, and we hope one day cures for glaucoma. So the directors are charged with raising money and otherwise looking after the affairs of the society, including its new website, governance issues, and dealing with financial affairs, etc. They also review the applications for grants that are farmed out to a jury of peers, followed by a recommendation from the Scientific Advisory Committee. The board makes the ultimate decision about the grants, and we're very happy to do that. We send out the money to all of the successful applicants. As Tom will mention later, the audited financial statements are available on our website. They were just approved by the board of directors at a recent meeting, consistent with our usual practice, and they will be filed with Corporations Canada in accordance with corporate law. The only members of the society now, after a change in 2014 because of the federal law, are the directors. That makes it easy to manage things. As members, the directors were, the members met recently and elected the board and reappointed Chaplin and Co. as the auditors for the upcoming year. And Tom can say more about that. And he's also going to say, I don't want to steal his thunder, but he's going to talk about the Scotia Waterfront Marathon and a few other things as well. Just a brief overview of what's to come. After Tom, we'll have Dr. Trope introducing our guest lecturer, Dr. Hutnik, and her colleagues, who will then present their presentation, which is a big part of why we're here. That'll be followed by a question and answer session with Drs. Trope, Bindlish, Bird, and Hutnik, dealing with questions that have already come in and those that may come in during the meeting. And I think we sent some information out with the invitation about how you go about that. After the question and answer period, I will come back and give some certificates of appreciation to some of our supporters and volunteers, and then we'll wrap things up. So having said all of that, I'll hand things over to Tom.
Thank you very much, Jim. I hope everyone can hear me. My name is Tom Gottlieb, and this is my third full year working on the board of directors for the Society and acting as treasurer. So I'm very pleased tonight to address you all and provide to you my treasurer's report on the financial operations and general operations of the Society. I'd like to welcome everybody to our to attend our first ever online annual supporters meeting. Frankly, we weren't sure how this is going to turn out, but we were very encouraged by the response and the large number of people that registered. We have attendees joining from all over tonight, from Toronto, from Hamilton, from Regina, from Vancouver, Ottawa, and even one person who decided to join from Ethiopia. So in case you're wondering what time it is in Ethiopia tonight, it's 2 a.m. So if you're out there listening, I hope you'll get some sleep after this. And it just proves the point that I often tell people: if you're finding that the pandemic is getting you down and you need a glass of wine to steady your nerves, it's always happy hour somewhere in the world, so you needn't worry about that. So while it was very nice to see you all in person in previous years at our annual meeting, clearly this format for our meeting today has a reach that goes way beyond the Toronto area, so we're quite happy and excited about that. So if I could have my first slide, I'll talk about the financial highlights for the year. So from a financial point of view, I have to tell you that we had a very, very good year last year. Our year end is May 31st, 2020, and we had revenues of $418,724, which was significantly higher than we've had in previous years. And we can, that's thanks to a large extent to a number of bequests that supporters provided for us in their estates. And we always are very grateful to receive funds from estates, as it really helps our cause greatly. We do have our, as Jim mentioned, our financial statements will be posted on our website shortly. Right now, if you look, the 2019 statements are there. They were just submitted by our auditors, so we'll be posting those next week, and you'll be able to get them from our website. Due to the funds that we received over the year, we were very pleased to award 9 research grants this year. One of them is to Dr. Cindy Hutnik, who is presenting some of the results of her research. And so we're looking forward to that very much. On the topic of revenue, we generate revenue from a number of main sources. Our society, as you know, is laser focused on our mission to research the causes, improve diagnosis, prevention, and treatment for glaucoma. And that's all that we do. We don't do anything else. We're kind of a one-trick pony in that regard. We don't try to feed the hungry in the world, rescue abused animals, or save the planet from global warming. There are lots of other charities that do that, but so we will not be bombarding you with emails that engage in high pressure sales tactics to ask you to donate funds. We won't be sending you cheap pens or calendars or post-it notes or keychains or address stickers. We only do the important research. And to let you know what's going on, we send out 3 mailings a year: the fall mailing, a small Christmas card just to let you know we're still here, and the spring mailing. These outreaches give you information about what the society is doing. In particular, the fall mailing, which you just received, will provide information and description of all the research projects that we undertook during the year. We always get or appreciate donations from supporters that they can donate directly on our website or send in funds through the mail. And as I said earlier, we really appreciate when our supporters leave us, remember us in their wills, and it gives us a big boost and helps us fund more projects during the year. Another major source of income is the Scotia Bank Charity Challenge, which is it's a race, it's a walk, it's a marathon where charities can sign up and not have to organize their own event, but they can participate in the Scotiabank event. And I'll be talking about that a little bit more at the end of my presentation. But we generate over $60,000 a year typically. We're off to a good start with the Scotiabank Charity Run, and it's going to take place on October the 18th. I will be talking about that a little bit more towards the end of my talk. Could I have the next slide, please? Thank you. So operationally, we had a very busy year as far as the office is concerned. Jim mentioned we're very pleased that Suzanne Marshall accepted an offer to work for us in January, and she's now our squarely in charge of the office as our office administrator. I'm not sure she really had a good idea of what was coming, because she had a tiger by the tails right at the beginning of January. Was the first year that we launched our research grant online portal, which is a set of web functions that allow researchers and scientists to submit research proposals online They come into the office, and Suzanne receives them, catalogs all the research proposals, registers evaluators. These are people that work with Graham and Katie on the Scientific Advisory Committee to evaluate the quality of the proposals that we receive and to score them so that we can rank them and determine where we should allocate the money for awards for the grants. We work hard to raise funds for glaucoma research. We want to make sure it goes to research projects that are really innovative and worthy of funding. So Suzanne took that on. The research proposals started coming in January and February. They were sent out for evaluation in March. We made decisions about the awards in April and issued the funds in May. So that's a big part of the reason that we exist, and it kept us very busy in the first quarter of the year. I like to say the fun never stops at the Glaucoma Research Society of Canada. We're working year-round towards the mission of the society. We don't just stop when the awards are granted. There are activities going on all year, as I mentioned, the newsletters, the research grant program, the charity run, and so on. While this was going on, during the year, we upgraded our computer infrastructure. Our website was not very good. It was slow, unreliable. It was totally rewritten last year. We talked about it. But this year, we moved it to a new Canadian host and upgraded our email service and improved our security capability to prevent hacking and theft. So all that was done this year. With Suzanne coming on board, we kind of re-engineered. I like the word re-engineered. I'm a professional engineer. I think I'm the token engineer on this elite board of ophthalmologists, lawyers, and accountants and doctors. So I ended up tackling the computer office procedures, and with Suzanne's help, we streamlined many of those procedures and allowed us to, in a timely way, work from home during this pandemic, which has been troubling for everyone. And of course, our biggest technical achievement is this online annual supporters meeting, which I think we're very excited about. So if I could go to the next slide, please. So I mentioned earlier that the Scotiabank Charity Challenge is one of our largest single sources of funds during the year. And the way it works is a number of us on the board and some others, some of our supporters have registered with the Scotiabank website. They identify that all donations that come in from their friends and family should be allocated to the Glaucoma Research Society of Canada. And in addition to that, there is another group of people working for a fairly new Canadian pharmaceutical company called Aqueous, and many of them are online tonight. And we're really grateful that they actually have 12 participants planning to walk in this charity challenge with us, and they've just started raising money. This was taken about a week ago. We're well on our way to our goal of $60,000. We've raised together about $32,000 so far. So it looks very promising, and we're Aqueous, by the way, is involved in providing medications for glaucoma and for dry eye and a few other things. So we're very pleased that they chose to participate, and all the money they raise and we raise goes to the society. So it's the race, by the way, or the run. I have to admit, we're not going to be running a marathon. we're not running at all. And if you look at the average age of the board of directors and so on, I think we're closer to 70 than we are to 50 or certainly 40. So we're actually going to be walking on October the 18th from because in previous years it used to be a waterfront marathon. Everybody went down to the lakeshore. 20,000 people gathered together in a big group and took off down the lakeshore and walked up to City Hall. So that's not going to happen this year, but we are walking from Avenue Road and just south of St. Clair down to Queen's Park and back up again. So we're going to cover our 5K walk that way. And it's not too late. If you visit our website, you can sponsor one of our participants, or you can register and walk with us if you'd like. And so we're very pleased that that's going on. And that concludes everything I think I'd like to say tonight. And with that, I would like to hand the gavel over to Graham, I believe, who is going to introduce our guest speaker tonight. Thank you.
Thank you, Tom. It gives me great pleasure to welcome Dr. Cindy Hutnik, this year's 10th Albert Waxer Lecturer. She's here tonight with her team. The team is made up of Dr. James Armstrong, Dr. Vinay Kansel, and in a few years' time to be Dr. Jacqueline Slomovic. Dr. Hutnik is a full professor of ophthalmology and pathology. She obtained her PhD and her MD at the University of Ottawa. She did her ophthalmology residency at the University of Western Ontario. She did her glaucoma training in Wisconsin in the USA. And I must say that Dr. Hutnik is the consummate academic. That means she's involved in patient care, teaching, administration, and research. In the area of patient care, she's internationally renowned as a glaucoma specialist. As a teacher, she's in high demand with medical students, residents, colleagues, and others. She's an amazing administrator. She is chair of the governing committee of the Academic Medical Organization of Southwest Ontario. She's been on numerous committees of the Canadian Ophthalmological Society, the Canadian Glaucoma Society, Eye Physicians and Surgeons of Ontario, and a number of expert panels giving advice regarding drug therapies. Dr. Hutnik is an internationally recognized glaucoma researcher. She's published over 110 articles in peer-reviewed journals. She's trained numerous students, more than 175 students, including PhD students, one of which is Dr. James Armstrong. Dr. Hutnik has a special interest in the development of new treatments for glaucoma or using existing medications to treat glaucoma, and that's very interesting. We therefore look forward to hearing her lecture tonight on the glaucoma neuroprotection study. Dr. Hutnik, thank you.
Well, thank you, Graham, and good evening, everybody. Graham, you've just made me blush, and that's not supposed to happen on webcam, but thank you for that very generous introduction. It is with utmost sincerity that I would like to thank you and your executive team for the invitation and the opportunity to be part of your annual general meeting. It's also without exaggeration that I would like to use this opportunity to express truly the impact that the Glaucoma Research Society of Canada has had not only on me as a clinician researcher, but on all of the students who have had the opportunity to participate in glaucoma research. So tonight we're going to use some of the next few moments to talk about the current study that was generously funded by the Research Society. But throughout that, we're going to talk about that underlying theme of impact, which I hope you'll all appreciate. So next slide. The best things in life are not done alone. They're done in teams. And I can't express enough how important this team of students have been in this project. Later on in the presentation, each of them will introduce themselves to you, and I'm hoping they'll share with you what it has meant to be involved with this project and the impact on their aspiring careers. So this is a little treat that I brought for you, and I'm sure you're going to enjoy that. Next slide. So our objectives over the next few minutes is actually, number one, to validate the ongoing importance of glaucoma research. It's been important in the past. It's important now, and hopefully we're going to understand how it continues to be very important moving forward. We all know that one of the most important things we can do in the management of glaucoma is to lower the pressure in the eye. But many of the doctors, and I'm sure all of Graham and Katie Bird and Raj will tell you, we have some patients where we get the pressure just as low as we can go, but yet they continue to progress. So we're always looking for something that can assist lowering intraocular pressure in managing our patients. The last thing that I would like to highlight is just the impact that the Glaucoma Research Society of Canada has had in creating new information for us as glaucoma doctors, but also helping our patients who suffer from glaucoma. So next slide. So the question is why? Why do we continue to think glaucoma research is so important? I had the opportunity to be a member of a provincial team which last year produced something known as the Glaucoma Quality Standards. And it was a consensus statement from the whole committee that not only is glaucoma the most common cause of irreversible blindness throughout the world, but we can't forget the enormous impact that it also has on our patients' qualities of life. So it's a disease that affects not only the eye, but it affects the whole person. So that's why we continue to need to do research. Next slide. So there was a study done, and it was a study that highlighted in Canada, there are a lot of Canadians suffering from glaucoma, more than 400,000 Canadians estimated to be involved. Next slide. If you look carefully at the author list, you'll see Dr. Catherine Burt, who's one of your directors, contributed very immensely to this publication, which has been cited throughout the world. It is Canadian data, and it's been cited throughout the world in terms of its importance. Next slide. The one thing about glaucoma that not only frightens me, but quite honestly, it sometimes offends me, because it truly is a disease which is the silent thief. The most common cause of glaucoma develops so painlessly and so gradually that majority of people who have it don't even realize they have it until it's too late. So most of the nerve is sometimes damaged before the patient even has any indication that they have glaucoma. Next slide. So the other scary thing about glaucoma is today in Canada, walking around in cities like Toronto, cities like London, cities like Regina, Saskatchewan, more than half of Canadians don't realize they have glaucoma. So obviously there's a lot of work that still needs to be done. Next slide. So again, you'd probably ask yourself the question, how can it be that people have lost so much vision and don't even realize they have it? So the picture on the left shows you what a street corner would look like if you had your full vision. On the right, you'll see what that street corner will look like if you have moderately advanced glaucoma. You can see that your straight ahead vision is still preserved until the very end, but much of your peripheral vision has been lost. And the problem is when you get to this stage, next slide, you're very close to losing the vision completely. It's very hard to rescue the optic nerve and the vision when things get this far. So obviously we want treatments that we can start earlier. We want to detect the disease earlier, and we want to jump in as soon as we can. Next slide. So the thing about glaucoma, and you'll see my mantra, I think, on the next slide. It's a disease that affects the nerve which connects the eyeball to the brain. So it's a nerve disease. But one of the most important risk factors is high pressure inside of the eye. And in fact, as of today, when we're gathering here tonight, the only effective treatment we know to just reduce the risk that glaucoma will come and get worse is by lowering the pressure inside of the eye. Next slide. So what I often tell my patients is it's a little bit difficult sometimes to understand because glaucoma is not a pressure disease, it's a nerve disease. But the only way we know how to reduce the chance it'll develop or get worse is by lowering the pressure inside of your eye. And perhaps during the panel discussion, we'll hear from the other doctors on the panel that we all have patients where we get the pressure just as low as we can go, and yet the patients continue to get worse. So this is one of the observations that has prompted our study tonight. Next slide. So the question is, once we've gone as low as we can go with the techniques and the management, the surgeries, the lasers, the medication, are there any other things we can do to lower that risk? Next slide. So what we did is, myself and my team, we wrote a grant, and we were very fortunate that the Glaucoma Research Society of Canada decided to fund it. Next slide. Now, what we did in this grant is we said, well, are there any drugs, next slide, that are already approved, that patients are already using for some other reason, and they've shown to have the ability to protect nerve tissue? Because remember, glaucoma is a disease of a nerve that connects the eyeball to the brain. So the question we had, could these drugs possibly have any influence on glaucoma? Next slide. So what we did is we did what we call a big data database kind of study. So we decided to use the Ontario Healthcare Administrative Databases and specifically look for what are called off-target effects of certain drugs. And what we wanted to know, do these drugs either decrease the chance of developing glaucoma or the worsening of glaucoma? Next slide. So a key thing is we on purpose wanted to look at people in our community in the province. We thought if we find some data to support this, these will be very strong pilot data that may help us fund future larger studies where we look nationally and even internationally. I'll explain to you on the next slide what we mean by off-target, so don't worry about that term yet. And the last point to make is that this was a study involving humans. For many of you who know me, probably one of my greatest passions is fiddling in what we call the basic science lab with cells and molecules, but what we try to do is always translate that type of research to humans, because at the end of the day, we're trying to help our human patients who suffer from glaucoma. So if you look at this slide, on the left-hand side, you're going to see a number of medications. And if you look at the third column over, you'll see that these medications have been approved for use in Canada to either treat Alzheimer's disease or to treat high blood pressure, not eye pressure, but blood pressure, or to treat cholesterol. Next slide. So these are what we call the on-target effects, or the effects that allow these drugs to be approved to administer to patients. But for all of us who've ever taken a medication before, we know that many medications have side effects. Now, oftentimes, these are side effects we don't like. But what we wanted to ask here, is it possible that some of these drugs have side effects that may be beneficial? Next slide. So this is what we mean by off-target. Now, again, we want to sort of still kind of move around in the target issue because we want to address the idea of does this help the optic nerve? But it was not the reason why these drugs were brought to market. We just wanted to see if they had possible side effects that would be beneficial. Next slide. So the first hypothesis was that the use of these medications or drugs in patients without glaucoma would reduce the incidence of those patients developing glaucoma. The second hypothesis we had, in patients who have already been diagnosed with glaucoma, and who also happen to be on these medications, does it reduce the chance that they will develop more or need more medications or more interventions because their glaucoma is getting worse? Next slide. Now, it's important for me to tell you that we're not here trying to prove anything. It's not a cause and effect. What we were merely looking for is what we call an association. Is there an association between using these other types of drugs and glaucoma? Next slide. What we hope for and gave some substance to this grant is that we were using what's called population level data. The so-called fancy term now we use big data. Let's see what happens in a lot of patients and see if there's some potential association. Next slide. So in the first part of the study, this is a little bit of the science here. We wanted to capture all of those patients on the Ontario database who we assume either do not have glaucoma or perhaps they're one of the 50% who don't know they have it yet. But at least we know that they're not on any glaucoma treatment. We then wanted to see which of those patients on medication developed a 5-year incidence of being put on medications or treatments for glaucoma. And what we did is we compared it to a group of age-matched normal patients who weren't taking any of these study drugs. So patients weren't on any glaucoma treatment. We wanted to see which were on our study drugs, which weren't, and then we wanted to look at the incidence of them needing glaucoma treatment. Next slide. So next slide. The next part of the study is we wanted to capture in those Ontario databases patients who had already presumed to have been diagnosed with glaucoma because they've received some sort of treatment. And we wanted to compare the group of those patients who were on one of those test medications to those who were not. And again, we wanted to look over 5 years, which of those patients needed a stepping up in their glaucoma treatment, whether it be more medication, a laser treatment, or surgery, with surmising that if they needed more glaucoma treatment, it means their glaucoma was getting worse. Next slide. So the data sources, we included the Ontario Health Insurance Plan, and in HOHIP, it captures more than 95% of services that are delivered by our doctors in Ontario. We also looked at the Registered Persons Database, which captures information from over 13 million people living in Ontario. We also captured and went into what is going on in the Ontario Drug Benefits Plan, recognizing that it primarily only will capture the data for patients who are over 65 years of age. Now, to put this all together and to give it some credibility and some substance, we made use of a very powerful entity, next slide, known as the Institute of Clinical and Evaluative Sciences. Not only do they have access to all of these databases, not only are they able to link these databases, they are a great analytical resource. Next slide. So in terms of what we're expecting, the study is well underway, and I'm sure the students might even fill you in at what stage we're at in the study. Next slide. The first thing that we are hoping for is to gather evidence that will support the potential protective effects of those drugs that we went searching for. The drugs not that have been indicated to treat glaucoma, but indicated to treat those other diseases. Next slide. Now, within each of those medication is an individual medication, but often within that group, we call it a class of medications. There may be other medications within that class that might be worth studying in our glaucoma population because of the potential strong theoretical rationale of how these drugs function. Next slide. And if indeed, because of this study, we find a strengthened association, it may actually justify the rationale to actually explore these drugs, specifically in glaucoma patients, in what are called prospective randomized clinical trials. Next slide. And again, we're not saying that these medications are likely to ever replace pressure lowering in the eye. I think that's still always going to be a very important strategy for treating glaucoma, but maybe, just maybe, they may be complementary and they may assist us in reducing the incidence of glaucoma or its progression. Next slide. So at this point, I'm going to stop talking. I'm going to turn the podium over to our team. And I think first on the list is Dr. Vinay Kansal.
Oh, thank you very much, Dr. Hutnik, for introducing me. So I'm Vinay. I'm one of the ophthalmology residents currently training at the University of Saskatchewan. I had my opportunity to meet with Dr. Hutnik now. It's been about 4 or 5 years back when I was a medical student and I had done an elective at Western University and had the opportunity to work with her. And since then, we formed a very fruitful research-oriented relationship, and I've been involved with many projects with her. This was the first project with her where we were actually able to obtain funding from the Glaucoma Research Society of Canada, and for that we are incredibly grateful, because without your support, frankly, this project would not be able to get off the ground. The ICES organization is a fantastic organization, but in order to get the support of their analysts and epidemiologists, funding is definitely required. And I think, as Dr. Hutnik had mentioned already and discussed in detail, our current management of glaucoma is truly just focused on lowering the pressure in the eye, which unfortunately for some individuals is not sufficient to be able to halt the progression of their disease. And so in our investigation, we are really trying to find potential associations with other existing medications that may actually help treat or slow down the progression of glaucoma through other mechanisms. Next slide. And so for me, I think it's a very interesting topic, and I'm just very, very pleased to be able to be involved. And also on a personal level, for me, this has been a very humbling and wonderful experience. Currently I am hoping to pursue further fellowship training in glaucoma surgery, working with the physicians here, working with Dr. Hutnik and others. I've really developed a keen interest in glaucoma and recognize that in our community and worldwide, it's a condition that really we don't have a full grasp on exactly what is causing glaucoma and how to quote unquote cure glaucoma. Really, most of our treatments right now are kind of aimed at slowing the progression and trying to improve quality of life. And I'm really hoping that over the course of my lifetime, we can perhaps come up with a cure. And so the support from yourselves at the Glaucoma Research Society of Canada has really enabled me to pursue both meaningful research projects and also engage with a community of glaucoma researchers and clinicians to further my personal goals. And for that, I am truly grateful. So thank you very much, Dr. Hutnik, Dr. Trope, and the whole organization and all the donors.
Sorry, Jacqueline, you're going to have to unmute. Unmute and just go one more time.
Thank you. First of all, I would like to say thank you so much for having me this evening. It's an honor and a privilege to be able to say a few words about our study. My name is Jacqueline Slimovic, and I'm a second-year medical student at McMaster University. I am also part of the research team under the leadership of Dr. Hutnik, who has kindly asked me to speak briefly about our neuroprotective study tonight and why I feel it's so important and how this opportunity will impact my future career aspirations. Please advance to the next slide. Thank you. Being involved in the study and in Dr. Hutnik's lab has had a tremendous impact on my future career aspirations. Firstly, through being involved in this project, I've been exposed to excellence in leadership and mentorship. Dr. Hutnik has assembled a wonderful team and inspires each member to strive for their personal best. Within her lab, Dr. Hutnik also facilitates collaboration, which has allowed me to learn from my fellow lab members, develop new skills, and to become a better researcher. Dr. Hutnik has taught me the importance of asking good questions, which brings me to the next reason why this study is so important to me. This study is exceptionally innovative as it uses neuroprotective medications that have already been proven safe and effective in the treatment of other conditions in order to treat glaucoma. This typifies the adage that great research builds on current knowledge bases in order to further contribute to scientific advancement. Finally, this project inspires me as it aims to treat glaucoma, colloquially known as the silent thief. One of the fundamental reasons that I've pursued a career in medicine is to enhance patient care. Thus, it's my hope that through this study, Dr. Hutnik's lab will be able to find a way to prevent glaucomatous damage and to preserve quality of life for patients. My colleague, Jake Armstrong, will now continue this presentation.
Hello, and thanks, Jacqueline. My name's Jake, and I'm an MD PhD student, meaning that I completed my PhD during my medical school education. Currently, I'm actually in the last year of my medical school education, and next year I hope to match an ophthalmology residency, like my friend Vinay you just heard from. Ideally, with this type of training, my future workday will be split between caring for patients and scientific endeavors focused on bringing new treatment strategies and improved therapies to patients. I love what I do for many reasons, but in particular, these two endeavors are extremely synergistic and will allow me to bring the best to my patients from the world of research and bring my first-hand experience attending to the needs of patients into the world of health science research. My job is to straddle the fence between these two worlds and bring perspective to each side of the industry. I was extremely lucky to be able to do my MD PhD under the extraordinary mentorship of Dr. Hutnik. With her direction, and especially with the support of the Glaucoma Research Society, I was able to augment my medical school education with scientific training that allows me to confidently draw on the solutions provided by the three main pillars of health science research: human medical research, animal models of disease, and cell culture, to better find solutions for the problems that tomorrow's patients will face. More than that, however, I was extremely lucky. It has given us the opportunity to pass on, in turn, these great experiences and skill sets to many younger learners, and for us to build a community of young ophthalmologists and vision scientists who are passionate about improving the vision of Canadian patients, and have the skill set required to address both the current and future needs of glaucoma patients. We're all extremely grateful for your support, and it would not have been possible without the generosity of each of you. Thank you.
Well, thank you for that really interesting presentation, Cindy and your team. Absolutely wonderful. I'm not going to officially thank you yet. Our president, Jim Parks, will thank you shortly. But I wonder at this point if I could ask Cindy and the questions and answer team, that's Dr. Katie Bird and Dr. Rajiv Bindlish, to come on. Thank you. I see you all there. Cindy, I thought perhaps we'd start off with a few questions specifically about your research, and then we'll open it up to general questions which have come in. We have approximately 10 questions in all, so hopefully we can keep on time. So, Katie, did you get a chance to ask your question before we all disappeared?
No, I didn't. Although I think we were thinking along the same lines because it's not that dissimilar from your question. But
Right,
Cindy, if I have a patient with low pressure glaucoma, particularly, who's getting worse, is it worth trying one of these? Not prescribing it myself, perhaps, but speaking to their family doctor and seeing whether one of this class could be attempted?
Yeah, well, Kate, I was going to do the tricky thing of asking you, Graham and Raj, but my short answer is, I hope people heard my answer. I would still be, the same holds true, whether the patient has high pressure or low pressure, that we have to be cautious about using drugs off target or off label for something they weren't approved. But that being said, I don't know throughout your training, I've certainly at conferences have had discussion, especially with some of my American colleagues, who, when they have those patients who are progressing and they just don't know what else to do, that's when they start saying, why don't we try ginkgo biloba? Why don't we try this? So even though it's off-label and it's not what it's indicated for, I think with no other evidence than discussing things at a meeting with another colleague, I see people sometimes go ahead and try things. And I think the key point there is the communication with the patient. Patient has to be informed at a level that they can understand what's going on, what are the risks of treatment, what are the risks of non-treatment, what are the benefits. So it was with caution that I would maybe consider this in a patient who is progressing despite low pressures, but still being very concerned that if it's off-label, there are risks.
Yeah, I'd be nervous myself. The adage, first do no harm, coming strongly to mind, prescribing things that I don't routinely do. Thanks.
So, Katie, can I? Well, can I just say, you've given talks on complementary medicine before. Would you consider some of those, maybe?
The evidence for all of the complementary, so non-medical interventions is pretty weak. Things that are relatively or almost completely harmless, such as recommending more exercise and a good, healthy, varied diet, I have no problem with that. But anything that comes with significant risk of doing harm, such as THC, CBD oil, some of the more esoteric things, even ginkgo, which is quoted fairly frequently as being useful, can, in some people, precipitate significant problems with blood clotting, or rather not blood clotting. So yeah, I'm cautious, and as you said, we'll talk about it with the.
Yeah, so just a couple of things. So first of all, I agree with Katie. I'm a little worried about recommending these medications to patients. I did have in my career one time where I had a bad incident of a patient where I did recommend ginkgo, and it wasn't a very good outcome for the patient. So I do recommend caution. Just a quick note, I would very much like to thank Santen for sponsoring this meeting. They were very helpful in getting this going. So I really want to thank, just point out to them. So Cindy, what kind of studies are required to study these types of medications to see their benefit in glaucoma?
Yes, my answer is going to. My answer is going to. I don't know why we're getting feedback now. Are you guys hearing me okay? So something that Jacqueline said is that when we move research forward, we first of all want to rely upon a strong premise of why it makes sense. So if indeed the type of study we're doing now shows the possible association, the type of research that would be needed in the future would be something called a prospective multi-center randomized clinical trial. So it would be prospectively, before we know the answer, we would be enrolling patients. We'd be putting some of those patients on these drugs. Some of these patients would not take these drugs, and then we would compare outcomes. And interesting again with the panel that we have here, historically glaucoma trials have used the outcome of visual fields, but I'm wondering now if we're specifically looking at nerve tissue outcomes, if we would resort to our OCTs, our diagnostic imaging tools now, where we actually measure the retinal nerve fiber layer. And maybe, just maybe, if structural damage precedes functional damage, we may be able to do these studies in a time period that historically will be shorter than the visual fields. We've known from other studies that it takes at least 5 years to really get an idea about if a visual field is changing because of the type of test. So my short answer is it would be a prospective multi-center clinical trial and maybe using diagnostic nerve imaging as the outcome measure.
Thanks very much. Are there any other questions, Katie or Raj, before we go into some general questions which were sent in?
I'm just curious, when do you think you'll have results from this study, Cindy? What's your timeline?
It's going along very well. We are on the tight timeline because, believe it or not, we actually respect the parameters that the Glaucoma Research Society puts out. So I know the team has just last week, met with the ISIS team. What happens is an ICES, and by ISIS I mean ICES, not the other ISIS. What this means is that the team actually really defines the question, because an ICES study is actually very expensive. So what they managed to do last week was to narrow it down, and then once we actually have the actual question we want to ask and the data we want to extract, it moves along quite quickly. So we're hoping by next spring, maybe late summer. What do you think, team? Do you think, Jake, what do you think? 6 months? Do you think we'll have our first set?
That would be very doable, yes.
Yeah, very doable. That's the nice thing about doing it. Once you've really got a nice question and you've got the ICES people on board, it tends to go along without too many glitches.
Well, thank you very much. It's very, very interesting. So, Cindy, perhaps we'll direct the question at you, but please don't feel obliged. You don't have to only answer, and we'll ask Katie and Raj. Reg is very used to answering questions. He answers them for our newsletter in a remarkably effective way. Much appreciated as well, Reg. Thank you. So, Cindy, we have a question here from someone called Merle, and she makes a statement, then asks a question, namely that given the close connection between glaucoma and severe dry eyes, why is so little attention paid to the dry-eyed situation? I'm not sure she's correct in saying we don't pay attention, but do you have any comments about that?
It is something that I think we've all recognized and struggled with, because if we look at who gets glaucoma, obviously it tends to be more of an age-related diseases, and we know dry eye and ocular surface disease, its prevalence goes up to close to 80-90%. So almost every patient has an element of dry eye at the time they're diagnosed with glaucoma. And you know, Graham, I don't know if it's because we as ophthalmologists focus so much upon one aspect, and of course glaucoma is the frightening aspect that can permanently impair your vision, that we sometimes lose sight of the fact that we should be co-treating the dry eye. So there are very effective treatments now available for dry eye. Now, the fact that there's many treatments suggests there's not one perfect treatment for everything. I think it's very multifactorial. I don't know, and I'd love to hear what Katie and Raj says. Do you think because it's a frustrating multifactorial disease? Is it because it's such a chronic disease that patients just fall off the rails? Do you think it's because their glaucoma patients actually do have more severe dry eye? What are your thoughts? So, Katie, what are your thoughts?
Yeah, I would say that as you originally alluded to, the vast majority of my patients have some degree of dry eye. And whether it's, I don't think it's because of the glaucoma, but it may well be worsened by the glaucoma treatment. So the drops that we put people on, because they're mostly the preservative is there to kill bacteria. And so it has effect on the living cells of the eye. And so it worsens the ocular surface, and that's dry eye is part of the ocular surface disease spectrum. There are things we can do, including there's a couple of preservative-free glaucoma medications, as you know, and they're often good choices for people with surface disease issues. Lubricating the eye with a preservative-free lubricant, even though more expensive, avoids another dose of preservative on an eye that's already having to take preservatives for their glaucoma management. And then, as you say, there are other things you can do with blocking the tear duct into the lid, increasing production of tears using various medications. Personally, once it gets to that stage, I usually involve a colleague with external disease specialty or someone who works on lids to help with it. But I doubt I ignore it, because almost every patient, the glaucoma doesn't cause as much symptoms as the dry eye does.
And Katie, I have to say that you published that PISO study that actually showed that the load of preservative can actually affect the outcome of glaucoma surgery. So I know you're a strong believer in what you just said.
Yeah, ever since that, I've been convinced.
So, Katie, that nicely answered Dawn's question, because Dawn asked specifically about whether you, not you personally, but whether ophthalmologists should be prescribing only preservative-free drops. I wonder if you'd like to.
I would if I could.
Sorry, you would?
Yeah, if we have one preservative-free combination drop, co-sold with that preservative, which is covered by the ODB. We have one drop which is approved for use, but is not covered by the ODB, which is a preservative-free Zalatan or latanoprost called monoprost. And for some people, they're willing to pay to take the preservative-free drop that the government won't pay for them when they're over 65. And sometimes it really, to them, it's hugely worth it. Their comfort level is so much better when they get off the last drop of preservative. And you can also get a couple of other drops made preservative-free at what's called a compounding pharmacy, who not a regular commercial pharmacy, but it's made as a one-off. And that's also very expensive and also much less easy to get. You have to be in touch with only one or two pharmacists in the city, and I don't know about how easy it is if you're in a smaller town somewhere else. So the options aren't as widely available as I'd like. Given a free hand, I would prescribe preservative-free the vast majority of the time.
Thank you. So Raj, we have a question from Vicky who really extends the same question, but this time to the eyelids, asking about blepharitis and inflamed lids. It's really the same question, I think, but do you have any further comments to make about dealing with inflamed, sore, red eyelids, colored eyelids, all sorts of...
Again, ocular surface disease, blepharitis, meibomitis are very common in glaucoma patients. And again, chicken and egg scenario, does it come just from age and dry eye, or does the glaucoma medications contribute to it? I do strongly recommend patients to do a few steps every day. One is a hot towel on the eye every day for 5 minutes. I do recommend they do something called lid scrubs. So they clean the base of the eyelashes with a mild cleanser. There are some commercially available ones, Blephagel, Calmo. Some people, I just recommend straightforward Johnson & Johnson baby shampoo. So those are two things that I definitely recommend. Having done some anterior segment cornea fellowship, low-dose doxycycline, which is a tetracycline medication, can be very helpful in treating lid disease. So if I have some very sort of uncomfortable patients with very active lid disease, I will prescribe low-dose doxycycline for 2 to 3 months to see if that will help settle the blepharitis. There are some other treatments as well focused at the meibomian glands, such as LipiFlow. I don't have a lot of experience with them. I don't openly advocate those treatments because people have to venture to a private clinic and pay out of pocket. And I really wonder how successful they are. But some majority of people, if they can persist with what I recommend, I do find it helps their condition.
And if I can just add, Raj, those are great comments that I think every glaucoma patient should be doing. And one caution is another medication that's sometimes prescribed for eye discomfort and eyelid discomfort are steroid-based medications. So they can come in eye drops or as creams. And glaucoma patients have to be very cautious when you take any medication that's considered a steroid. Yes, it'll make the eyelids feel better and the eyes be less red. But if you use them chronically, it can actually make your pressure in your eye go up quite high in some patients. So I think what Dr. Binlish just mentioned is by far the safer approach. And if you do it religiously, I think it's just a good plan. And there's really nothing harmful about anything you've suggested to treat the ocular surface.
Yeah, it is definitely a major problem. And there's no doubt that we cause some difficulties for the patients and for our cornea external disease colleagues who constantly are receiving these patients from us. And every now and again, they tell us to stop the drops completely and to consider alternatives. And there are alternatives. They also come with risks and benefits. There's lasers that you've written about, there's surgeries. But we do create a lot of problems with our eye drops. So I think we could spend all evening talking about this. Perhaps I could move on slightly. Still another question by Vicky. She says that she's had a little bit of trouble getting to the ophthalmologist with regard to her red eyes. The ophthalmologist didn't have their office open and requested photographs of the eyes. So it brings up the whole issue of COVID and access to eye care, which is a little bit beyond the scope of this meeting. But I wondered if you could tell us in London whether everybody is back at work. Cindy, are people being asked not to attend unless it's absolutely essential? Where are we with COVID? Can patients come in with red eyes to see you? If not, how do you deal with such situations? Thank you.
Well, that's a great question. For 3 months, the Ivy Institute of Ophthalmology was shut down. So we had a huge backlog of patients that weren't being seen. We opened up in a staged way where we were assigned days and clinic space just to keep our patients properly spaced. When I see patients, I'm all wrapped up, and we have plexiglass shields. So the answer is we've ramped up, and we've ramped up pretty significantly. But what's happened is in Ontario, some of the optometrists have kind of gone on a partial strike. So we're having a lot of patients coming in through our urgent care and then being sent off to our eye care urgent, what we call clinic. And probably the busiest week I've ever had in my whole career was when I was on call about 2-3 weeks ago. It was just inundated with patients having sore red eyes because they either hadn't been seen during the 3-month shutdown or their optometry offices aren't open. So one thing they've done in London, they've actually named a doctor as what's called the chief information officer to look more closely at telehealth and telemedicine, and then teleglaucoma is being explored by the Canadian Glaucoma Society. Because I must admit, I don't know what your opinion is, Graham, but doing ophthalmology in a telehealth way is a little bit challenging since so much of what we see is partly the picture, but again, the eyeball's attached to the whole patient. So I think we're moving in the direction of artificial intelligence, taking pictures of parts of the eye and sending them in. But it truly is, I think we're on the cusp. I think what COVID has done is made us think about what are different ways that we can utilize to take care of our patients, and maybe access to care will be made more possible for people who can't get into a urban center. So I think we're looking at change over the next 5 to 10 years and how we do things.
Katie, Raj, any comments?
Yeah, I think perhaps we need to recognize that telehealth between a family physician and a patient, a lot can be done over phone or with a computer link such as we're using tonight. But when we talk about telehealth and glaucoma, we're really talking about a distant ophthalmology office with all the equipment to do visual fields and OCT scans and check pressures, being linked to an interpreting office at another center. So kind of hub and spoke. But it's not something that can be done by a patient in their own home. I did a few phone calls with people, but I can't do my job over a computer link at the moment with someone at home. And so if people can't come in, I can't assess them properly. I hope that the technology will allow us to do some of these remote visits for underserviced areas, remote communities, flying communities, what have you. But for most of my patients who live in the Greater Toronto area, they're going to have to come and see me, just like my cat is.
Raj, any further comments? Any experiences?
To be honest with you, I'm not a big fan of tele or virtual ophthalmology care at present. Being a more community-based ophthalmologist, I had the luxury of being able to keep my office open to some degree. Obviously with full protection and screening, but I wasn't shut down by a hospital. Unfortunately, some our other colleagues here, their offices are in a educational institution, and so they're under a different mandate. But I have to admit, there are many different causes of a red eye, and it's not necessarily just an allergy to the glaucoma drops. I've seen people with red eyes who end up having very bad infections, or they could have inflammation in their eye. And the critical point is they need a slit lamp exam, and that slit lamp can't be done virtually over a computer. So it is a difficult situation, and I think a triage over the phone could really tell us, do we have to see you that day or the next day, or perhaps then we can say, okay, let's give it a few days with these recommendations, but then a definite level of follow-up, and I think that's important.
Thank you very much indeed. We only have one last question. Time is going by, and as long as Katie isn't attacked and eaten by that leopard behind her, It would be great. So this is an interesting question, perhaps aimed at you, Katie, because of some of the work you've done. And the question goes like this: because of poor vision and dexterity, sometimes I find it takes 2 or 3 tries to get drops to land in my eye. I searched eye drop dispenser and eye drop guide and found on Amazon many plastic devices that fit over your eye and try to center the bottle over your eye. Are these products safe? Are they effective? Are they recommended? And is any particular type better than others? So perhaps, Katie, if you could take a question and then we'll hear from the others.
I think you were referring in your introduction there to a study I did quite some time ago, looking at one particular type of eye drop guide. And we asked people to use it and to rate it and tell us whether they liked it or not. And in fact, the majority, a lot of people liked it, but the slightly larger number didn't like it and didn't feel it helped and didn't want to go on using it, which was disappointing. I haven't got any sort of comparative evidence of brand A versus B versus C. So I think I would say, like I do with my artificial tear eye drops, pick one, start with the cheapest. When you find one you like, stick with it. There's no doubt that putting the drops in can be a definite technical challenge. And unfortunately, sometimes the pharmacists don't recognize that patients can waste a drop or two when they're putting them in and run out earlier than if they were doling out a pill where you take one pill and one pill only. And so if patients run dry early, they need to tell their pharmacist to get a refill. Yes, I ran out a week early, I still need my drops.
I had an interesting experience a few days ago. One of my patients hadn't put his eye drops in when he came in to see me. And as usual, I got very irate when he honestly told me that. And I said, well, why didn't you put the drop in? He said, well, my wife didn't have time to put it in. So it reminded me of the fact that you actually can train most people to put in their own eye drops correctly. You really can. And I think patients should be trained, and we as ophthalmologists don't do a very good job. We need to show patients how to put the drops in. We need to make sure they know how to do it. And studies have shown that if we do that, the outcome is actually very good. You can train people to put their own drops in. And to expect others, like wives or children or friends or nurses, to put the drops in is not ideal. Now, obviously, there's some patients who have to have the drops put in. If someone's in a nursing home who is, doesn't have the dexterity. But most of the time, you can train most people to put drops in correctly. I don't feel about that, Cindy or Raz. Have you had similar experiences at all?
I agree.
Yeah. Go ahead, Cindy.
Oh, no, go ahead, Raj. Go ahead.
No, I was just going to say it's actually quite an interesting experience because periodically I will ask my patient to show me how they put the drop in, and it's quite interesting how many of them use the drop. And I think the fault is on us for not really showing our patients how to use medications, especially the early glaucoma people we elect to treat with medication. We should be spending an extra 5 minutes with them to actually physically show them how to open the bottle and how to apply the medication. We just sort of say, here, these are some eye drops to use. I'll see you in a few weeks to see how they're working. And I think that is just the downfall of us being very busy. Perhaps we should be training our technicians to spend a little bit of time after we've seen the patient to go over that. But I think it's a very important thing that we should be doing.
I just want to add, we did a study with one of my residents who was a trained ophthalmologist from Egypt, but he came over to his credentials in Canada. Simple study where I prescribed the medication for the first time, and then the patient went with him in the other room and with an artificial tear showed how they would use the drop. And some of the patients were actually putting the drop under their tongue because, again, through language barriers and just huff and the fuff, they didn't realize that the medication was for their eye. They knew it was for their eye, but they thought they put it in their mouth. So patients, when they aren't given the full instruction, we're leaving it up to them to decide how to use the drop, and not every patient certainly knows intuitively how to do it. So I couldn't agree more with what everybody said, is we have to almost take the time ourselves or our staff to guide patients when they're new users of eye drops?
Well, thank you very much, everybody. We could stay and talk for a long time further. I have no doubt about it. I think at this point I'm going to hand over to Jim and ask him to thank Dr. Hutnik and team. And again, many thanks, Katie, many thanks, Raj, and many thanks, Cindy and your team. It really has been great fun. Bye for now. Jim?
Pleasure to see you.
Thanks, Graham. That was certainly very informative. Just picking up on the discussion about how to put drops in, I would be remiss not to remind people, if they aren't aware of it, or if they are, that we put out a brochure a few years ago precisely trying to educate people about, physically how you put the drop in your eye. The other questions I've come across are, once it's in, how long do you hold it? How long do you delay between the first drop, the second drop, the third drop, or however many you're on? So those are, I think, all things to be discussed as, excuse me, perhaps in a newsletter. And so now I'll turn over to the last really official part before I make some closing comments. As I mentioned at the outset, we take this opportunity to give certificates of appreciation to volunteers and supporters and others, and this year is no exception. So we're going to do that right now. First, and just picking up on Graham's comments, I'd like to express again our thanks to Dr. Hutnik and her team. That was certainly, I found, very, very enlightening. So what we're putting up are pictures of the certificates that ordinarily would be in a frame and set out with a real signature on it, but this is a facsimile this year, along with a lot of things we're coping with. So thanks again, Dr. Hutnik and your team. Next, I'd like to recognize Don Johnson, who's been a terrific financial supporter over the years, and we can't say enough about his contribution to the welfare of the society. And Don has shown up at some of our meetings in the past, and I certainly hope he can do so in future once we get back on our feet. Next, Stuart Murray, one of our directors. This is in recognition of his huge amount of work in designing and implementing our website and the research grant portal, which have been very helpful in dealing with applications and just more generally totally upgrading our ability to communicate with the world out there, particularly our supporters. For those of you who haven't tuned into the website, I encourage you. It really is quite a remarkable achievement from a few years ago when we were sort of way behind the times. I'm just looking at my notes here. Next is Dr. Burt, in recognition of her contribution to designing, specifying, and otherwise dealing with testing the research grant module that really is helpful now in processing applications. We're getting away from a lot of the hard copy and snail mail and those things that we were faced with previously. And finally, last but not least, Santon Canada. I mentioned them at the beginning. We're extremely grateful for their sponsorship of this evening. And this is just a small token of our appreciation. I should say, when the pandemic hit and we realized we couldn't have a real meeting, we had a debate about whether we would just cancel and let it go. And on further thought and realizing other organizations were struggling along, we decided we'd proceed. And this webinar is a result of a lot of work by a lot of people. And I think it's gone off fairly well. I would like to take just 1 minute here. I hope I can backtrack. It would have been too much to expect everything to go completely smoothly. I realized after introducing the directors that I hadn't formally introduce Suzanne, our administrator, by putting her photo up. So there she is. Sorry for the delay. Maybe you'll get a little more notice now than just coming after the directors. I hope so. As I mentioned, all of the directors are extremely appreciative of all the effort Suzanne has put in, particularly through the pandemic, putting together this webinar, dealing with the grants, etc. We wouldn't be anywhere without her. So that completes the formal part of tonight's proceedings. Just before closing, a few offhand comments. COVID, of course, has put everything up in the air. We're trying to improve our communications with our last newsletter, and I think some of the invitation to this webinar. We're inviting people to let us know the best way to communicate with them. It's less costly for us if we can avoid mailing out a lot of hard copy with all the postage and printing it, etc. So if you can give us some feedback on that, it would be extremely helpful. I think we'll send out a survey after this just to see how we've done, and invite anybody who's got comments, whether in the survey or just offhand, to let us know. Get in touch with Suzanne. You have her contact information. We'll continue to send out our newsletters, as Tom had mentioned. So I hope next year we don't need a webinar. We can meet in person at a convenient time and place. But if that isn't the case, we'll carry on and take it from there. So with that, I wish all of you well. I hope everybody stays safe and healthy. And if we're not in touch otherwise, we'll catch up at a real meeting next year or at another webinar. So thanks very much for participating, and good night.